podcast, and it's a podcast that we started because we are a married couple that deals with schizoaffective, depression, anxiety, and all sorts of extra things, and we realized that we weren't alone, and so we wanted to talk about it and encourage other people to. So that is what we do, and we're really excited to talk to you today, Dr. Fox.
Yeah, thank you. I appreciate you reaching out to me and inviting me to come and talk a little bit about what I do and the videos I'm making and all that good stuff.
Yeah, for sure. When I came across your videos, I just was really struck by how much you really seemed to care about the people that you were talking to, which was really nice because, there's a lot of great YouTubers and there's also a lot of great doctors, and they're not always the same people.
Regretfully, yeah. I've heard that. Yeah, and I think that there are people who misunderstand personality disorders, people who are frustrated by them, particularly borderline personality disorder, which is what I've been focusing on the YouTube channel lately, or for the most part. And my students, it's interesting, when they first start working with me, and we'll go over somebody's chart, and they'll see borderline personality disorder, and they'll be like, oh my God, I don't want to work with them. And I usually ask them, well, have you worked with someone with borderline personality disorder? And they said no, but they're horrible. And I'm like, well, wait a minute. And then we start kind of, or I start kind of educating them a little bit about what it is. Just as you mentioned, like schizoaffective. Schizoaffective is very rare. It's very difficult to accurately diagnose. So it's often confused, and usually you go through a lot of misdiagnosis, very, very similar to borderline personality disorder, until you actually find it. And what's interesting is a lot of my students, they tend to be very advanced doctoral students, and after they'll work with that individual that they were initially sort of afraid to work with, or they had all these ideas. I always say fatal attraction, but my students are much younger than I am, so they're like, what? I've never seen it. So then I'll say, well, Gone Girl is sort of an extreme example of someone who's borderline. Certainly she has antisocial traits in the movie, certainly. But if you just focus on the borderline, she really hits all of that in that movie as well. And so we'll say, that this isn't what you're working with. What we're working with is an individual and on that spectrum, and add some reality. And that tends to be a very rewarding experience for a lot of my students. Once you understand or sort of have a trajectory on working with these folks.
Yeah, I actually did go through and watch Fatal Attraction, and it was really interesting because I'd never seen it without knowing about borderline, and then knowing that it was something that a lot of people referred to when trying to describe what it looked like. And I just watched it, and it was like, man, wait a second, who's the bad guy in this movie? Because I'm a little confused, and it was like, man, that must be really difficult. If you really feel all the emotions at that intensity, it must be a really hard and isolating world.
Yeah, and I think it is. And a lot of folks who are dealing, with borderline personality disorder, I mean, they really are, because a lot of them attach very quickly. In my videos, I talk a lot about my theoretical approach and things like that, which is about core content and surface content. And if you see, a lot of that core content, which drives a lot of those surface behaviors. So the core content would be that emptiness and loneliness, and sometimes fear. Fear is a complex one. And then the way that it's expressed is the surface content. And the surface content would be, just to go back to Fatal Attraction, right? So she cuts herself, she threatens him, she stalks him, and of course, because it's Hollywood, they have to blow everything out of proportion. And then you end up with a misunderstanding of what the diagnosis is. And Fatal Attraction back in the 80s, I worked in a movie theater, and when that came out, I remember when it came out, just to date myself. And so everybody walked out saying, "Oh my God, what is this person? Who is this person?" And then they start saying, "Well, she's borderline personality disorder." And it was like, "Oh my God, those are just the worst people." And it's just not like that. I mean, there's such an extreme and a spectrum. And I was talking to a professor. I'm in a suburb of Houston, and I was talking to a professor at University of Houston. She's an expert in the area of borderline personality as well. And we were talking, and she's like, "I wish that people would understand that these, individuals who have this disorder seek out treatment and, when they're ready, participate in treatment. And it's okay when they reach a point where they can't continue in treatment. And, and there are ways to manage that and, make it an effective way to sort of resolve treatment or put a pause button on it and things like that. But, it's nice that people that are really kind of in the borderline personality sort of research and treatment community understand that they're not people that are, if you remember the bunny scene in Fatal Attraction, right? They're not there's a very, very small percentage of individuals that are diagnosed with borderline personality disorder that actually go to those extremes. And,
Right.
It's a shame that gets generalized to the other, 98%.
Right. And, I couldn't help but thinking, like, if maybe instead of trying to continue to hide the affair from his wife, he had, taken her to the hospital when she had slit her wrists, maybe we wouldn't get there. Maybe if it made it okay to get that treatment,
Yeah.
it would have been a little different story.
Right. Well, they're both manipulating each other, right? So maybe they both have a little bit of borderline in them for sure.
Yeah, for sure.
Mm-hmm.
Yeah. So, gosh, it's such a hard one because I've heard so many people use those stereotypical descriptions of it. I've also heard a lot that there's a lot of bias in therapy and within the medical community against borderline personality disorder. But I've also heard that it's really treatable and that you can get some pretty good results from different treatments.
Yeah, absolutely.
So, why do you think that that stigma continues so strongly? Is it just because people don't realize it's treatable, or?
Well, because I think that what happens is that so when I do my seminars, so I often travel around the country and I run seminars on cluster B personality disorders, which is where borderline personality disorder is. It's in that cluster. And so there are other mental health providers. They can be psychiatrists, social workers, marriage and family therapists, things like that. And I think that a lot of them have a misconceptualization of what it is. Because again, they're all back to the fatal attraction idea. They're all back to that they're all cutters, that they're all, stalkers, and they're all, and I think that's just been perpetuated. And I think what's interesting is because if it's on a spectrum, and a lot of times they'll say, you probably have a friend who's really fun to hang out with, and he or she is really interesting, right? They're a little wild, and maybe at times you're like, oh my God, I can't believe that he or she did that. And, and if you look at that, some of those could be borderline features. Some of those, there are people who meet criteria for borderline personality disorder and manage it with effective skills, with effective strategies really easily. They come into treatment. They're in treatment for 6, 8, 12 months, learn those strategies, and off they go. Those aren't the people. The problem is when they go for treatment to a psychiatrist, psychologist, mental health provider, the mental health provider doesn't see that as borderline because the only way they're identifying them is when they are destructive. And we'll just say the upper, 2%, right? Which is your Glenn Closes, right? And your fatal attractions. And so they don't understand it. And as we kind of go through the seminar and we talk about, this is how I go about, working with these folks, and these are the trajectories, and this is how I get people intrinsically motivated to participate in treatment. And a lot of times they're like, oh my God, it's very new to them. But what I teach is outside of a typical paradigm or treatment strategy, which today a lot of folks use cognitive behavioral treatment, which I think is good, but to a degree. I think that there are other theories and modalities and strategies that need to be put in place before you can get to a cognitive behavioral per se strategies or strict worksheets kind of approach, which I think is what a lot of mental health providers want to do at this time.
Man, that must be really hard for someone who might be struggling with it to identify that they have a problem before that point.
Yeah.
Because they wouldn't even know what borderline looks like on a smaller or lesser scale.
You mean for the client or for the therapist?
For the client.
Oh, yeah.
Maybe they're not realizing that they even have a problem necessarily, or that they're on that trajectory of needing help.
Mm-hmm.
So I guess it would be really cool to hear in your words what it looks like when someone has borderline personality disorder on average, I guess, what the more typical patient kind of displays.
And then I just want to just to throw it out. So I don't use the term patient because I like to use client, because patient implies, it comes from a passive participant, and I like client because client, it has this idea that you're going to participate with me. It's you and me working together. And a lot of people, you use patient, and so I always like to kind of throw that in there. So that's just a little aside, just kind of throwing that
Absolutely.
in.
No, that's a great point. I kind of use them interchangeably, but that's a really good reminder to stick more with client because of the implications there. Yeah,
because medical doctors, right, you're a passive participant a lot of times. You may ask questions, but then you're just going to passively take the medication, and then you go on from there. Whereas a client, you have to participate in treatment, you have to be an active participant, so on and so forth. So when I first start working with someone, and over probably the last 7 years or so, the folks that have been coming to me have been more personality disordered and things like that. I work with some other folks that don't have that diagnosis, but so I'm not always sure. But lately, as of late, I've noticed that the majority of folks that are coming to me are cluster B folks, typically individuals with narcissistic personality disorder or borderline personality disorder. So if I sit with somebody, it's sort of, I always kind of just blank canvas, let's kind of see who this person is. And what I'm listening for is core content, not necessarily the stories. And stories, or happenings in their life, because that's the surface content. Underneath that, what I'm listening for is what's driving it. So, if you're having problems with your spouse, is it a similar problem? Did you have that problem last month? No, last month he did this, and it may, the colors of the story may be different colors, but the foundation is the same. The issue tends to be the same. So what I'm looking for is core content, typically abandonment, emptiness. Sometimes there's self-hatred. There can be worthlessness, and I'm listening for these things that are factoring into how this individual functions and why they're responding the way they are. And so as I hear more and more of that, then I'm like, okay. And my sniffer, I call it a sniffer. Is that I've kind of, you can kind of smell it after a while. I'm like, okay, well, we're kind of going down a BPD road, and when I do that, I tread very lightly, because surface content is not really well defended, and I'll explain that in just a second. But surface content are the stories, right? Is that, they'll tell you the stories of the happenings and experiences that they've had. But when you go to core content, you hit defense mechanisms because they're well defended. When you get to working with abandonment, how do you overcome issues of abandonment? By building this concept of self that you no longer, you build up a concept of self to a point where you don't need someone else for you to feel full, and if that person were to leave, you recognize that if you've had one relationship, the odds are really good that you'll have another one. So, I mean, statistically, right? It's just right there. Yeah. And so, and I've worked with folks that had exceptional abandonment fears, and they built their sense of self, and they built, the life around them that is rewarding for them. As they did that, their significant other typically self-selects out. And that means, that they're like, well, they can't get them going anymore. They can't hit their triggers. They can't, get them really sort of sailing off. And they get frustrated, so they amp up their behaviors, and then they get frustrated, and then they leave, which can kick off abandonment issues. And that's where, if you work early to prepare, and that you're working with someone with borderline personality disorder issues, and abandonment is a core content, you build that up. So when that person leaves, he or she is like, yeah, relationship probably wasn't this great anyway, and sometimes it's hard. I mean, to let unhealthy people self-select out is hard for anybody, particularly though, I think for cluster B folks and borderline personality disorder and histrionic personality disorder folks as well. So I hope I clearly answered your question.
I think so.
Okay, good.
So I guess to the layperson, another thing would be like, why do we not treat this like someone being overly dramatic? How do we know? Or, because I hear it so much that people really think that it's like a cognitive choice, like, oh, I know what an appropriate way to behave would be, but I am choosing this way. And like, think people feel like there's a lot of choice and manipulation in it, and it seems like it's really just motivated out of like almost reactionary, like, oh, no, stop, like, I kind of need you to stop leaving me, or to prevent the thing they're afraid of.
Yeah.
If that makes sense.
Yeah, and I think that in a lot of folks, it's Monday morning quarterbacking. And I think, so what happens is, right, is we're all supposed to eat right, but we all have those times, right, where, like, the Cheesecake Factory. I really like Cheesecake Factory. I love that Godiva cheesecake. And should I eat it? No. But when I go there, it's like there's this compulsion to eat. I'm like, I am going to plow through that thing like nobody's business. And now there, there's premeditation there. But let's say if I'm trying to eat right, I'm trying to do things, and I know what appropriate behavior is, but here comes this slice of cheesecake that is like divine. It's got the little chocolate piece in it. It's got the whipped cream in it. I mean, and it looks really good, and there's a little chocolate thing on the plate and all that stuff, and you just plow through it. Now, and then afterwards is when you have the thought process or reaction that people who don't have BPD think beforehand. So
Gotcha.
you have that stimulus, you engage without that process of reasoning and you fall into reaction, and then afterwards you have regret, intense regret. Most of my clients, when they do engage in a behavioral outburst, have intense regret for it, and typically they're not outward hurters. They're typically inward or self-hurters, so self-harmers. I think that it's a misconceptualization. It's like, well, they know what they should be doing. No, I mean, they probably do know, but the problem is that they haven't learned because, and I don't know if you can see, I know it's kind of dark on my side, but this is how a lot of folks with borderline personality disorder kind of think that life works, right? Here's stimulus, here's response, and there's no space in between. Well, here's what therapy is. Therapy is this space, right? And that is mental health providers. That's our job, is to increase this space as much as we possibly can, right? And so we know here's the behavior, here's the response, but I have to reason different choices, right? So if I'm watching what I eat and I don't want to be, tempted to plow through that piece of Godiva cheesecake, I'm not going to go to the Cheesecake Factory, But if I haven't reasoned all that, and I end up in a situation that's like the Cheesecake Factory, I'm not going to think about it, and I'm going to go right at it. And they end up in these situations over and over and over again. And even though it becomes repetitive, it's a slow learning process for some of these folks, depending on where they are on that spectrum. So even though you have that initial behavior, and then you have the response, that if they don't, first of all, if they haven't learned a strategy that works for them, right? There's some strategies that work for me. There's some strategies that work for you. There's some strategies that work for your husband that you mentioned. And, but that's not going to work for everybody. So we have to find the strategies that work, how to implement them, recognize the stressors that are in place, then as best we can, because there's surprise stressors too, right? So then we have to prepare for unknown stressors. So how do you prepare for the unknown? The way you prepare for the unknown is by building skills, and that becomes years of borderline personality disorder treatment, and all that. So I know that people and family members get really frustrated with folks, and they're like, oh, you know better. When you're sitting in reasoning, you can say, yeah, you know what? I do know better. I do know that a 1,500 calorie slice of cheesecake is not good for me, and I shouldn't do it. But I'll tell you what, sometimes if I'm walking by Cheesecake Factory and it's just that time of day and it's just right, we all do it. We all, do things we shouldn't be doing. But these folks, I think that because they have less space here and they haven't learned those strategies, don't walk by the Cheesecake Factory. Don't call that boyfriend or girlfriend that sets you off, right? Don't buy alcohol and keep it in the house, right? Don't go out with your friends who drink and drug. Don't go to a bar, or don't, I'm really bad with all the apps. I don't know if Tinder's popular anymore, but but right, if promiscuity is your issue, don't have Tinder on your phone. These are strategies, but it takes them learning this, and people are just like, well, you should know. That's not fair. It's unfair, and that's part of why I work with these folks. And why I think I have so much compassion for them, is because it's so frustrating to hear other mental health providers say, well, they should know better. Are you kidding me? Like, I'm like, what? And then, then I'm like, okay, we got to get into education mode. I got to educate you about these people. And it's been an uphill battle, but over the last few years, I've gotten very fortunate that more and more people are listening. So that's good. I think the stigma is lessening, because I think as more people in the field, the researchers and clinicians and mental health providers are getting exposure that this is a good prognosis diagnosis, and they're like, oh, it is? Yeah, it is. Mm-hmm. Yeah.
That's so cool.
Yeah.
So if there's one thing that you could tell someone who was facing a borderline personality disorder diagnosis, and have them really take it to heart and kind of take that with them as they face this, what would it be?
That it is a treatable diagnosis, and that I think so. Ideally, if what I would want these folks to hear would be that it is a treatable diagnosis. Okay. Now, a lot of people say, well, what's the cure? Like, I'll get a lot of responses, in comments and stuff. Well, there's no cure for it. Well, no, there's no cure for the common cold either. But, there's a lot of things that there isn't a cure for. But what we do is we treat it. And if we treat it, we can manage it. So there are things that we can do to manage, your likelihood of getting the flu. So there are things you can do where you can manage your likelihood of having a borderline fluoride reaction. So that it is a treatable diagnosis. That skills are critical, and I think sometimes the hardest part is kind of accepting where they are and the reality of where they are. And I think that it's hard for folks that are along the spectrum to say, I trust you enough to help me. And I get that. I don't have new clients very often, because I work with people for years at a time. But I've had people who've waited a long time, to see me, and we'll get started, and we'll keep it clean, but they'll tell me what to go do with myself, and they'll be, I can't wait. I can't believe I waited. You're the answer guy. You're supposed to have the answers. I'm like, well, no, I don't have any answers. We were going to do this together, and sometimes off they go, and they're not ready for that process, and I respect that too, But so that is what I would want folks to know, is have hope that it is treatable. Allow yourself to accept help when it's out there as best you can, and learn those strategies, learn those skills, and learn as much about the disorder and your presentation of it as best you can. There's just some great books out there. A lot of people write and say, well, I'm in a rural area, I don't have anybody near me or anybody, that I can go see. And there are good books. I often, I suggest Matthew McKay's book on dialectical behavioral therapy all the time. I'm waiting for someone to say, you must get a kickback because you're suggesting, and I don't even know him or anything. But I think it's such a great book, and I give it to so many of my clients. And they say, oh, I hate this part of the book, but I love this part of the book. Great. Any part of the book that you love, let's dive into it and let's focus on it, because it's all about skill building. So that's a long answer. I have a tendency for long answers.
That's totally okay. I think it's really needed for people who maybe have heard and been shut down by different treatment providers in the past, to hear someone have some words of kindness and encouragement for them. So I think that's really helpful. Seems like it would be to me anyway. So what can loved ones, like family and friends, support people? Is there anything that's like vital for them to know right away about supporting someone with a new diagnosis of borderline personality disorder?
Yeah, and I think, get educated as best you can. Get educated with your significant other, with your son or with your daughter. Don't read separately. Learn about it together. If you're having a meal or a coffee or something, talk about, understand the process of it as best you can. There is a new book coming out, and I haven't read it yet. but it's on, talking to folks, talking to loved ones who have someone with borderline personality disorder. I'm sure that the title is better descriptive than what I've just said, but yeah, and I think, working with them, I think that also you have to have boundaries. I think that a lot of folks that are in families or in relationships with folks that have borderline personality disorder, they have sort of unvocalized, I'm sure there's a word, I apologize for that, but I have a little allergy thing. So it's an unspoken, there we go. So it's an unspoken boundaries that they're like, well, they'll tell a friend or their aunt or their brother, sister, cousin, well, if he or she does this, I'm not talking to them anymore. Well, but they don't know it, because they think, just to go back to what we talked about, they'll say, oh, well, he or she should know that. I mean, but it's about talking about what those boundaries are. People think that I'm really nice, and that's good. That's one of the things I like about myself, is that I'm nice. But at least I think I'm nice. But in treatment, in therapy, I'm really clear, and boundaries are super, super clear. And because a lot of times, individuals with borderline personality disorder do kill themselves. People with borderline personality disorder do struggle, and they struggle to pay their bills, and they struggle to connect to others, and all these other things. And so in treatment, it's we take it very seriously. The boundaries are clearly described. When you miss treatments, how many treatments are you permitted to miss until I have to end the session? That's really clear, so there's no guesswork. And most people, by the time usually by the second or third session, they've sort of opened up a little bit, and we talked a little bit, and they realize that I was brought up saying that if you say it, you should mean it, and so in treatment it's the same way. I don't blow smoke or anything. I'm real straightforward, and I think my clients feel really safe in that, but also they know that these boundaries are really clear, and I think that loved ones need to be very clear and verbal about what their boundaries are, and stick by them. The one thing that I learned from my mentor, that because he was an expert in personality disorders, and he's been in the field forever, and he said, he goes, if you don't tell your client the truth, you have to transfer that client. And he goes, that sounds extreme, but as soon as your client knows you're a liar, you are useless. And I wholeheartedly believe that. And I think that, if I tell my client, well, all right, if you miss 2 sessions, we're going to have one session where we talk about the continuation of treatment. And if you don't want to continue, that's fine. But if you're going to continue, then, then we're going to have to show up on time. And that goes for me too. But if then they missed it again, and I was like, okay, well, all right, we're going to go one more. I'm a liar. And I'm, and it does the client a disservice. And I think family members fall into that too, because they're like, well, I don't want to set him or her off. You can't control that person. All you can do is be honest and upfront and caring. And most of the folks that I know, again, 98% of them, they may not like to hear it, but if you're honest and they feel like they can trust you and that what you're saying is genuine, they may test the boundary a little bit, but you have to follow through. And sometimes it sucks.
Yeah. Are you a parent at all?
Yep.
Okay. It sounds a lot like, I have two boys. It sounds a lot like parenting, and not to infantilize anyone, but it just sounds like the reaction with kids,
Mm-hmm.
They just need to build up that time, and it's like a little part of it got slowed down, and their emotional reaction time and things like that. And it sounds like the same thing when you're disciplining and teaching a kid, not just disciplining, but like setting good boundaries and saying, okay, if you do this behavior, you're going to have a timeout, and it's really clear. So I guess, if you have a friend, not in a demeaning way, but thinking, okay, in this area, they're not developed, or they don't have really strong muscles in that emotional development area, so I need to give them a little grace, just like I would a kid who was trying to learn a skill and develop in that way.
Yeah.
So I don't know. Maybe that would
Yeah.
Maybe that might be helpful if someone's thinking about it
Oh
that
yeah.
way.
No, and I think you're absolutely right. I mean, just as in dealing with anyone, it's always nice, the people whom you deal with, to know that they are who they are. You know, I grew up in New York, and I'm currently living in Texas, which is very different. The culture is very different, and they're both great. But I don't know. It was in New York, it's kind of it's a very different approach than a southern approach, as opposed to a northern approach. And I think that the people that I have around me are very blunt, very clear, and I've learned about friends over the course. I think as we all have, people you can trust and people you can't. And imagine though if they're not your friends and that's your parent. Imagine though if that's your doctor. Imagine though if that is your loved one, significant other, or whoever. And individuals with borderline personality disorder, they jump into relationships quickly. They have intense connections to others, and they want a lot of what is often called passion, or whatever it may be, so they can get into these relationships, and they become these massive relationships. And I think that I lost my train of thought. So we can edit this part out. No, and I think that when things become unclear, so then people that when you rush into these relationships, you don't know who they are, and if they're less than upfront people, and for some reason, I mean, I don't know why, and this isn't derision, this is just example, is that I think with my clients, what I see is that they seem to be really good at picking people that lie and cheat and harm them and disrespect them, but then they're connected because of that fear of abandonment and emptiness. They're like, well, I don't want to be alone, and you want to get them to the point that, well, alone is okay, but that goes back to not having that consistency, not having that parenting style that is clear and direct. No one likes to punish a kid. Nobody likes to put their kid in timeout. Nobody likes to have their kid cry or whatever. But I'm okay with it, because I recognize that this is what we need to do.
For sure. I mean, and how many times has it taken? More than one time we've learned this lesson.
Right. That's right. And that goes back to our example, right? It goes back to that skill, right? To behavioral response. It's like a kid very much, in that over time you're lengthening that space. Now your kid, at 5 years old, right? It's very, oh, that chocolate cake, I want it, and then, but when they're 15, they have a higher reasoning center in their brain, so then they're able to most likely, depending on their developmental experience, but then they're able to say, wait, I'll hold off on that, because if I eat it before my dinner, then I'm going to get in trouble because I'm not going to eat my dinner, whatever it may be. So I think, it's about building those skills, but also having that consistency. And it is like parenting in some ways.
Yeah. Wow, that is so amazing. Like, just listening to you talk more about it, and it really seems like it's just a group of people that's really just needs a little extra guidance and acceptance so they can move in to start getting treatment.
Yeah.
Because it's an ugly label right now, but it's becoming less so. Mm-hmm. So if we could just remove the ugliness from the label, it would really open the door for a lot of people to be able to kind of come in and be in a place where they can build themselves up and get a solid sense of self. And yeah.
Oh yeah, no, absolutely. Mm-hmm.
I think that's all of my questions. I'm still learning how to wrap up an interview. So,
well, I think you did great. So, but what were your expectations of this interview? What were you hoping to get?
Just to hear you talk more about it from someone who really knows their stuff and has had a lot of experience in it, really. Mm-hmm. And I keep hearing more stuff, and it's like, man, what a hard diagnosis if your healthcare providers, like, not just that they don't know what to do with you, but it feels so personal at that point. It's not like, oh, sorry, you have lung cancer and it's at stage 4, there's nothing we can do. It's more like, it seems like people are being treated like, oh, you're we don't like you very much.
Mm-hmm.
And that kind of sucks. That just seems just a bad thing. And I just think we're all so intrinsically valuable, and we have so much to offer that I hate seeing people kind of dimmed out before they even get a chance.
Right. Yeah. Yeah. And you're right. And it's I've talked to a lot of medical doctors and things like that. About borderline. They all have stories. Of to go back to that 2%. They're all like, oh, if I see someone has a borderline diagnosis, oh my God. And I'm always like, well, I said, but think about the other 98%, right? You have your 2% story, but the other 98% who you see who don't have the diagnosis because they're not the Glenn Closes, they're not the Gone Girls. And when I say that to them, I think, and this is my opinion, the good doctors are like, they think about it. The ones that aren't that good and that I tend not to go back to and see or talk to are the ones that are like, and I mean, if you're going to dismiss me, then I can't imagine what you would do, to a patient. And so I think, we have to choose our providers too.
Yeah, definitely. I guess it's kind of like going back to cancer.
Right.
A while ago, we didn't have a cure for it, but now we do have more treatments. It's not always a cure,
right.
But sometimes there's stuff that we can do about it. Sometimes we cut out the tumor. Sometimes there's chemo, and we've come a long way with that. And so we can't treat borderline personality disorder the same way that we did when we didn't know what the treatment was.
That's right. That's right. I think you're absolutely right. Absolutely.
Oh my gosh, it's been a pleasure talking to you.
Thank you.
So much.
Yeah, same here. Same here. I enjoyed it.
Well, I so appreciate your time, and I'll make sure to put all of the ways that people can find you down in the show notes, as well as, do a whole intro for all your amazing qualifications. Because seriously, I was like, oh my gosh, there's so much information here, and it's so cool to talk to somebody who has so much under their belts on this stuff, because I only started learning about mental illness in depth like a year and a half ago when my husband started going downhill, and it was like, oh, I wish I would have known a lot of this stuff way before now.
So. Sure. Well, good. Well, I'm glad that I was able to help you out. I'm glad that I really enjoyed this. This was a lot of fun. So I appreciate it. Yeah, and then I'll put in the comment section. I'll make a YouTube video of this as well, and then I'll put in the comment section so people can hear your podcast, and they can learn more about you and what you're putting out there.
Awesome. Well, thanks so much, and have a great night.
Thanks. You too. Take care. Thanks again.
Bye-bye.
Bye-bye.